when I was younger practicing, I would have older patients that would not take opiates because they didn't want to turn into a junkie. And I tell them, look, if you're a junkie, we'd know by now. You're not. You're not going to be a junkie. On the other side of the spectrum, I know for a fact that, quote, normal people do not understand the power of craving. I mean, it's not a willpower issue.
No, right. Not at all. Craving is something that overtakes your life.
It does. And again, I am one of the most will-driven people you're going to meet. And I didn't beat cravings on my own. I beat it by medication-assisted therapy. I beat it by going to a psychiatrist that I trust implicitly. I beat it by going back to meetings. I beat it by exercising every morning. And I allow myself the indulgence of sugar because I figure I can burn those calories off, and that's the least harmful addiction I got.
Hello, and welcome to the Saving Dose podcast. Thank you for joining us here today on our podcast, wherever you are and however you are listening to us. Whether you're coming through our website, thesavingdosepodcast.com, or through your favorite podcast platform or YouTube or however you found us, we appreciate you listening to here today. We got a very exciting episode here today to talk about today. I'm really excited. I'm Will Pedranti. I'm one of your co-hosts. I got Dr. John Hsu. How you doing, Dr. John?
I'm doing great. Thanks, Will.
Yeah, absolutely. Here today. Kendra Allen, our other co-host, couldn't make it here today, but we are really excited. So if you remember, the Saving Dose podcast is about all things addiction recovery. That's what our topic is. So whether you're a patient or a caregiver or a nurse or a doctor or a friend or somebody just interested in learning more about addiction and the issues around addiction, how we can do better things to fight addiction, this is the podcast for you. So thank you for being here. I'm really excited. We have a very, very special guest joining us here today. I want to introduce him. Coming to us from New Mexico, is that right?
Okay. We
got Ernie Dole here. Yeah, a pharmacist by training, a professor at a point in his career, and somebody also that struggled with his own issues with opioid use disorder. So we're just thrilled to have you. Thank you so much for being here, Ernie. I just want to start off. You can just take a few minutes introducing yourself and your background, where are you from, how you grew up, how you became a pharmacist, and your life. To get our listeners to get to know you a bit better today.
Sure. My name's Ernie Dole, like pineapple. I grew up in Denver, and I'm the second of a fraternal twin, which, I'm 56. I don't think neonatology existed a whole lot. So we were born like 6 weeks early, and I was the bigger one at 312. So there's sort of a roll of dice from the beginning. And then I think one of the things that probably shaped my life more than I wanted to admit for a long, long time was I used to have really bad asthma. And to the point to where, the only thing that really managed it was like a triamcinolone or Kenalog shot every 3 months. And you could see how bad my asthma was by just how round my face was from about 4th grade through 10th grade. And so when I decided, I graduated from high school and about, I think a junior or something like that, I decided to go into pharmacy because I didn't want to be anywhere around needles that somebody else was control of because of what amounted to PTSD from being admitted about 10 times over a 6-year period with status asthma. And so pharmacy seemed like a natural fit. And at the time I was good at doing drugs, so it seemed like a really nice fit. And I don't know many people who actually make a career out of their substance use patterns or opiate choice patterns, but it actually worked out pretty well.
Oh my gosh, that is so interesting, right?
So when I graduated, I was working in what was then Colorado General, and after about a year, because you could reciprocate licenses for a year, me and my best friend decided to go down to the Virgin Islands and work as pharmacist in Charlotte, Amalie, which, again, in retrospect, was probably the worst place for a budding opioid user to be because there was no control whatsoever.
Right.
And then that lasted actually lasted the winter. So after the winter was over in Denver, I decided to go back, mainly because I could see the writing on the wall. And just if I stayed there, it was going to end badly somehow. And after about a couple of more years of working as a staff pharmacist, Carl General, I got bored. And again, I wasn't going to go to med school, so I went to PharmD school. And the top 3 programs when I applied were I think 3 or 4 programs like Minnesota, Tennessee, I think Kentucky, and Texas. And then growing up in Colorado, you have a natural animosity towards Texas, so that was out. And Minnesota was way too cold, and so I went to Tennessee. And I guess I can tell this story. I went to PharmD school, was doing well until actually my drinking got in the way of showing up for tests, and the dean actually called me into his office and threatened to disenroll me.
Wow.
And I also knew at the time that, he'd been sleeping with students for grades and all this, and I had cards in my hand if I needed to use them. And
My God.
And I mean, I was like 25, and it was like, and I said, I'm not leaving until I get, because I had nowhere else to go. I mean, if I dropped out of school, I had nowhere else to go. And I at least realized that much. And so I told the dean, I'm not leaving until I get this degree. So what do we do? And when I went through a hearing, anyway, I got back in, much to the dean's chagrin, with the guidance that if I stepped out of line one more time, I was gone. And did a residency at the Memphis VA. And at that time, really, there was so much, the culture shock going from Colorado to Tennessee was so much. I just wanted to get back west of Mississippi. And got a job. Our female Husky's here keeping me company now. You can see her nose.
Yeah.
And I ended up at the University of Arizona at the Tucson VA doing surgery and critical care. And it was a great, great job. And after about, I don't know, 6 or 10 years, I started getting restless again. And really my counterpart at the University of Minnesota was a gentleman, a really nice guy by the name of Brian Erstad, who was just a star in pharmacy that I was never going to compete with. And this job in New Mexico came open on a grant for developing a Native American Center of Excellence. And so it meant going from surgery and critical care to outpatient. And I made the transition. And the best part of the whole story is, during the interview for this job, I ended up meeting my wife.
Wow.
And we've been married 32 years. And we got married, but we've been married over 30 years.
Wow,
And
congrats.
And that was the best thing that happened. Awesome. And so I moved to New Mexico and got tenure. And then after I got tenure, I got bored again and went to go direct a pharmacy program in a for-profit corporation. Unfortunately, that was a no-win proposition because by Medicare standards, pharmacists are not healthcare professionals. And we can only bill, and still can only bill, at a level of 99211, which is a simple nurse's visit. So there was no way I was going to make my salary. And in a for-profit organization, that just wasn't going to fly. And so I also found out that I am a much better clinician than I am an administrator, that I really suck with rules. And after not enjoying my time as an administrator, I went back to UNM and developed and implemented the clinical pharmacy program at their outpatient chronic pain center. And that's where I finished out my career. And it was great. We built a great program. And the best thing about it was that, well, one, we got busy enough we had to hire a second pharmacist. But by hiring a second pharmacist, we actually dealt with the problem patients, which meant that the anesthesiologist doing epidurals didn't have to really leave the floral room, and made enough money to hire 4 fellows. And we hired another nurse practitioner, another PA, really as a direct result of, since we couldn't bill, it didn't matter how long we talked to people or patients. So we could talk to an firm for an hour, we could talk to them for 15 minutes. So really, we ended up with the majority of the problem patients. the PA and the nurse practitioner did trigger point injections and worked people up for epidurals, and the anesthesiologist spent the bulk of their time doing epidural injections in the floor room. And what made this possible was the work of a gentleman by the name of Dale Tinker, who was the executive director of the New Mexico Pharmacy Association. And it took him 20 years, but he pushed through a piece of legislation called the Pharmacist Clinician Act, that where if you were a pharmacist and you met a series of protocol and requirements, you could enter into collaborative practice agreements with physicians. And what that agreement was defined by you and the physician. So I developed a protocol where we saw almost all the opiate patients. They're all the patients on opiates, which increased accountability, which increased safety, and we got to know the patients more. But again, also freed up the nurse practitioner, the PA, and the anesthesiologist to do what they did. So everybody was practicing at the top of their license across the board.
Yeah, but Ernie, there's a 1 to 10 framing of healthcare providers dealing with, getting hooked on opioids and getting OUD and developing OUD, and it's greater than the general population. Do you think it's the access to drugs and the rationalization that we think we know what we're doing that healthcare providers end up with a higher degree of opioid use disorder than the general population?
I think so, and especially after we talked yesterday and the day before, I think that upon retrospect, I had a level of cockiness that. Well, let me actually back up. I think my whole life I've had addictive behavior. I remember one episode when I was a kid, somewhere younger than 10, where my mom came around the corner and I'm just shoveling sugar into my mouth with a teaspoon, which is not normal behavior. And she was aghast. So she took the sugar bowl, put it on top of the cupboards. Being a very goal-directed child, I saw where the sugar bowl was, got a chair, hopped up on the counter, got the sugar bowl, and just continued doing it. That's not normal behavior. And so...
Is that the moment you knew that you had an addictive behavior, and the moment you knew that you could possibly develop an OUD?
No, because I was probably 10, but in retrospect, I realized that as a moment to where I had that type of personality. That...
they talk about adverse childhood events, or ACEs, and many people talk about ACEs leading to 3 times the rate of OUD as an adult, because women, 50% of women are actually sexually assaulted.
Bingo.
And children as older adults, and many of them end up with PTSD, and they end up with depression and end up with anxiety, and most people get drugs from their doctor for those things, and before, anxiety and depression was sometimes treated with opioids.
Right, and I think I think this is a quick side note. One of the things I noticed about every female patient I saw, and 95% of my patients were female, was that every one of them had at least one incident that could cause PTSD because of ACE. And often when they would tell me the story, they would go to their adult figure, and the adult figure would blame them and make them the perpetrator. And I have a feeling that all that rage, abandonment, betrayal got turned inwards because it wasn't safe to show that outwards. And that's where fibromyalgia gets its seeds, I'm very sure of. And so I think, and only recently have I gained the insight and admitted to myself that these asthma episodes probably counted as an adverse childhood event. I mean, during one episode of hospitalization, the kid next to me died of asthma at 11. I remember looking around, and at the end, I recognized it later, but there was always an intubation cart next to me. And so for a long time, I had this attitude that, I could take on anything because I took on this and I wrote it out and I won. And I think to some extent I still have that attitude. But
Well, do you think your expertise in pharmacology as a pharmacist sort of help you rationalize drug use
yeah.
and opioid use and kind of gave you an advantage?
It gave me a level of, I don't know if it was an advantage, but I think it gave me a level of arrogance and cockiness that, I know about this. I graduated with honors. I'm incredibly bright. I can deal with it if it happens. In retrospect, what I actually became better at was just covering my tracks, which I guess is one way of dealing with it.
Yeah.
Yeah, there's a lot of anesthesiologists that are addicted to
Yeah.
fentanyl or propofol or benzodiazepines. I mean, I touch it multiple times every single day of my adult career. And, it's really, it takes a lot of heart to just say, well, it's not for me, it's for the patient. But, there's a lot of doctors who have a problem. And, what do you think about the peer assistance programs for pharmacists and doctors and who have OUD?
My experience with them has been really not as a patient, but more as a counselor and all that, or a peer evaluator. And I'm glad they're there because they're often just the last lifeline for somebody. And again, before I relapsed, I had 30 years of recovery, a continuous sobriety.
Wow.
And the reason I relapsed, I'm sure of, is the last 10 years I didn't go to AA meetings. I had some other addictions that I thought would cross cover for it, and it didn't. And I don't know why, but one afternoon I just decided picking up a pint of Jack Daniels was a great idea, and within a week I'm drinking a fifth. And so,
oh my gosh.
So
Jeez.
all those things you hear are true. And I think I had a level of arrogance that told me I'm special and it didn't matter, or something like that. And
well, there's a lot of people who have OUD, and sometimes they reach out, but professionals don't like dealing with these patients because they take up too much time in your clinic. They're aggressive. They could be arrogant. I mean, what do you think is the time frame to help deal with these patients? Is it a year, 2 years? You said you didn't use for 30 years.
Right. I didn't use for 30 years when I was going to AA meetings and working recovery. But then again, it took 10 years, but then I drank. I will say that for me, I've been on buprenorphine, I think, for 10 years, maybe, or more. And I think putting a time limit on that is a stupid idea because it's a lifelong disease.
Yeah, absolutely. It's a chronic medical condition that we should be totally treating for the rest of these people's lives.
Right.
Because, at any moment you can relapse. The relapse rates are 90% without treatment, 90% with treatment. But we need to really get people treated. And, the one thing that I find to be even incredibly ignorant of everyone involved is the distinction between opioid dependence and opioid use disorder. They're absolutely not the same thing.
No.
You have cancer patients who have been on opioids for years, and then you want to stop them overnight? We're taught in medical school you cannot rapidly taper drugs for any reason for any patient because they will have rebound effects. When that 2016 CDC mandate came out, there were a lot of patients that were they couldn't get opioids. Many patients died.
Many patients committed suicide.
Yeah, the one thing that really makes me sad is these American veterans. Men and women who fought for our country, they can't get treatment for PTSD, for injuries they suffered protecting our rights for freedom. And they go to the parking lot of the VA hospital and commit suicide there to send a message. But the problem is, I don't think anyone's listening.
And I have a point of view that is definitely in the minority that I hope will gain some popularity. But I turned 70 June 21st. For my age group, I am convinced that chronic NSAID use is more dangerous than chronic opiate use. And
Thank you very much.
and I wish more people would believe that, because I've had patients and family members who were on diclofenac, which was my favorite NSAID to prescribe, but it cut one of them's renal function in half. It just happened to be picked up on a physical. And so, yeah, you have decreased renal function, you have upper GI bleeds, you can induce asthma, and everybody thinks they're safe and you can take them like candy. And they, I think, are much more dangerous physiologically than opiates are at any level.
Well, let me ask you this. If you had a knee replacement and they only gave you Motrin and Tylenol, would you think that that's possible?
No.
Or reasonable?
Because I've had 2 knee replacements. And because I'm not near as athletic as I think I am. And I have hyperlax joints. But I think I think Tylenol, Motrin, I mean, it's just the only people that makes feel better are the people prescribing the medicine, and that's it, because they don't have to worry about the opiates. But they're also not worried about boxing somebody's kidneys either on an 80-year-old.
They really should, because, we're supposed to treat our patients to the best of our ability,
Right.
Not treat people by guidelines that don't understand that treating an 80-year-old with Motrin 800 3 times a day, it's going to kill their kidneys.
It's going to end. It's terrible. And I did, and I get. Let me back up a little bit. I do not think, except for maybe antibiotic resistance right now, there's any class of medications other than opiates that induces the passion that they do. And I mean, I would have older, when I was younger practicing, I would have older patients that would not take opiates because they didn't want to turn into a junkie. And I tell them, look, if you're a junkie, we'd know by now. You're not. You're not going to be a junkie. On the other side of the spectrum, I know for a fact that, quote, normal people do not understand the power of craving. I mean, it's not a willpower issue.
No.
Right.
Not at all. Craving is something that overtakes your life.
It does. And again, I am one of the most fiercely competitive, will-driven people you're going to meet. And I didn't beat cravings on my own. I beat it by medication-assisted therapy. I beat it by going to a psychiatrist that I trust implicitly. I beat it by going back to meetings. I beat it by exercising every morning. And I allow myself the indulgence of sugar because I figure I can burn those calories off, and that's the least harmful addiction I got.
Well, you did the right thing because, opioid use disorder and recovery really requires mental health, behavioral health to treat the mind, and it also requires a medication to treat the body. As holistic treatment, then there becomes the best treatment. Because, abstinence, in AA, as you know, abstinence
doesn't work.
is successful 7% of the time.
Right.
And, we have medications like buprenorphine, the one you're on, that can reduce opioid deaths by greater than 50%. And 75% of people can't get it and don't get it.
I know. It's ridiculous. Now, and put it in a different context. You look at the way addiction's defined by a lifelong chronic disease, and that fits hypertension, that fits depression, that fits hyperlipidemia. And we have no problem prescribing meds and overprescribing meds for those conditions. But when it comes to this condition, bias and passion get in the way of rational therapy, I'm convinced.
I think, it's ignorance too, because I have patients who have, they've been on 300 MMEs of morphine, and they're working, and they're not abusing.
Right.
They're opioid dependent. But people have complained that I am prescribing too many opioids for this patient, I'm a pill mill doctor. And yet these patients have
Productive life.
300. If I tried to stop one pill, they could go in withdrawal. And that causes an ER visit. That's 20,000.
And you would have to,
I don't know.
and you'd have to put them on a much more toxic medicine, NSAIDs.
Yeah, there's a lot of other medications because I used to do what's called multimodal pain therapy.
Well, me too. That was my life.
Yeah. And I'll tell you, I used to do a lot of pain blocks as well. And there was this one episode in which one of my esteemed colleagues accused me of practicing Chinese medicine on these patients. You know, it's like
Not racist at all.
This is a state of the art, right? Right now, if you don't practice multimodal pain therapy, Medicare actually will penalize your hospital 1 to 2% because their patient satisfaction scores are lower.
But then look at so again, let me use another medication, clonidine. Clonidine, you take that away quickly, people rebound, and you are strongly cautioned never to abruptly DC clonidine because of the physical withdrawal symptoms, right? Somehow that logic goes out the window with opiates.
Yeah, and you know, I am so frustrated because, you know, we're doctors, but we have lost the art of medicine. I find that to be incredibly, it's really annoying.
Well, and
because my patients,
you lose,
they deserve better.
Right, and you lose the ability to connect with people. Because if you're stuck in a 15-minute algorithm, and there were days that I ran an hour or more behind, but my patients got used to that because I spent the time with them when I saw them. And I just don't think, again, I think in so many ways trying to teach addict behavior to normal people, even though we need to do it for education, is trying to describe color to a blind person. Because they're two different sets of perceiving the world.
Yeah, but, you know, I know we're running up on time for our podcast, and you've been a great guest because, you know, what you've done is you've ignited some passion for me. I don't usually come out and speak with such passion because I'm trained to be calm in a very pressure-packed situation.
Yeah.
But, you know, this is awesome. It really is.
Let's do it again soon so we don't lose momentum, but also not overtake the podcast.
I want to set certain messages. I know we're ending, but, you know, I want to give you a chance. What message would you give to either a pharmacist or an anesthesiologist or a nurse? What would you say to them right now? What would you want them to hear to help them get into treatment so they can live? Because, you know, it's 2 years from the time that you begin OUD uncontrollable to the time you die.
And I think my main thing would be compassion. I mean, granted, I know when we are active in our addiction, we can be real hard people to deal with. That being said, think about compassion and think about how good people do with treatment. Think how they could turn around their lives. I mean, really getting put on buprenorphine saved my life. I wasn't drinking. And, you know, that was going to kill me very quicker than anything. And I just have, if possible, the same empathy for somebody with any other chronic medical condition that you have for, say, somebody with cancer, somebody with degenerative joint disease, somebody with depression. Have that same amount of empathy with somebody who's an opioid use disorder patient. Because there is very little difference in so many ways.
Yeah.
That's really good, Ernie.
That's incredible, Ernie. Thank you so much. I love that compassion. I love that last sort of message, compassion, because that's what I've heard, you know, being involved in addiction the last year, I guess it's been that I've been sort of diving into addiction. is, I met with somebody recently, and she says, I hate that we call it a disorder because it makes it feel like there's something they're doing wrong, right? Or something wrong with them. It really is a disease or a condition, and it's chronic. And just like you're saying, it's chronic. You deal with your life. You, as you said, Ernie, recognized at a very young age you had this predisposition, right, of addiction, and saw how that played out when the opportunity and all kinds of things like arrogance, or we talked about trauma or PTSD or these kinds of things that can impact, that can be that switch that gets somebody to end up in addiction, right? And that addiction sort of taking over their life. So I love that. I love having that compassion, right? And that's an important piece I want to take away for our listeners to remember that this is a disease that it's not people's choice, right? And they're fighting it every day. And it's a struggle and it's a battle. And like you said, I know, John, both you guys, craving is incredible. It is absolutely incredible to try to harness that craving and keeping it from destroying your life and taking your life. So I love that you're on here. Thank you so much, Ernie. Thank you for just being so honest about your life and what you've gone through. I really appreciate that message. We'd love to have you back on.
Great. I'd love to do it.
To talk more.
Realize we just scratched the surface of the whole subject.
Yes. I know we did. So I wish we had more time, and we're going to set up an opportunity where we can spend more time talking about this. But thank you, because that's what we're trying to do here in the Saving Dose podcast. Just what you're talking about. Get the message out there. Let's talk about addiction. Let's talk about addiction recovery. Let's be honest about it. Let's be transparent about it. And so thank you so much for our listeners out there that are listening to us today. Hope you guys took away some good messages here today. We appreciate if you want to follow us on YouTube, or subscribe or like or whatever, all those things you can do when you on our website or on YouTube or the social media. We appreciate that, to share this with others so we can hear it. And thank you so much. Thank you, Ernie. It's always a pleasure, Dr. John. Thank you so much.
I hope to be back soon, you guys. Bring me back.
We will. I promise we will. So that's it. Have a great day. This was the Saving Dose podcast.
And you got to meet my cat.
I like the cat. Just perfect. Time to exit with the cat.
You guys take care.